Welcome to tonight's webinar. My name is Allie Armstrong. I'm a field marketing specialist for Axonics therapy and will be moderating this webinar. This evening, Dr. Wyatt will be speaking about bladder dysfunction, the common symptoms patients experience, and treatment options that may help you regain control. Without further ado, I would like to introduce Dr. Wyatt.
Hey, how's it going, everybody? So I'm Dr. Bryce Wyatt. Good to see you all here. So just a bit about myself. I'm from Warner Robins, Georgia. Went to Medical College of Georgia, University of Georgia, in Charleston at MUSC for residency, and I've been in Atlanta now for around about 4 years or so. So this is one of the things that I typically do. I'm big with endourology, BPH, voiding dysfunction, incontinence, prosthesis. Those are kind of the typical things I treat. I am located in Roswell and in Sandy Springs. So, bladder symptoms. So I'm sure some of y'all are well aware this is seriously can disrupt your life. So oftentimes people will stop drinking before they go to bed. Throughout the day, they won't drink if they know they're going to go on a trip. You can miss, if you're watching a movie, you can miss parts of it. And oftentimes you memorize every bathroom, every restaurant, every place that you go to. So if you go to the mall frequently, a lot of the people with these kind of issues know exactly where every bathroom is so that they won't have any issues. So this is super, super common. In fact, around 50 million people in the United States typically are affected by this condition. Honestly, that number is probably way higher, especially in the male population, usually because gentlemen typically will not talk about their issues, or they'll just say, oh, that's normal for me. As I get older, this is a problem and I'm just going to deal with it or suck it up. And that doesn't have to be the case. So just a little about the condition itself. So overactive bladder is what we define as a sudden urge to urinate and the inability to hold or control it. Now, urinary retention is essentially the opposite. It's difficulty with urination and unable to empty the bladder completely. So if you're not emptying your bladder completely, you'll simply sit around with like a half tank. So if you imagine your bladder holds 500 cc's, if you only empty 250 every single time that you urinate, it doesn't take you very long to get back up to 500. So you're going to be peeing very frequently. So how is bladder supposed to work? So as the day goes on, obviously the bladder fills up, depending on how much you drink, how much you urinate. What goes in must come out. So when the bladder feels like it's at capacity, whatever that capacity is for you, nerve signals go back to your brain. Your brain then tells your bladder, okay, it's time to urinate. So it sends a signal and causes your bladder to squeeze. Now, when the bladder squeezes, we have to have a simultaneous relaxation of the urethra and the pelvic floor muscles to allow urine to get out. And any kind of dysfunction in this process can lead to some of these symptoms. So what is overactive bladder? OAB is a much quicker way to say it, but it's the frequent or urgent need to empty your bladder, and oftentimes it can lead to incontinence. So urinary incontinence is when you have involuntary loss of urine, often requiring pads or diapers. Frequency is urinating, many times a day. The American Urological Association says around 8 times or more a day would be too much, but that's different for everybody. Obviously, if you're drinking lots of water, 8 times a day may not be normal. If you're not drinking very much at all and you're peeing 8 times a day, well, that could be abnormal. Nocturia, we would consider that to be around, over 2 to 3 times a night to urinate. So 1 to 2 is normal for just about everybody. Over the age of 25, essentially everyone in the population is going to be waking up at least 1 to 2 times a night to pee. So we're trying to work on these things and fix these things. It's very important to understand, where is your baseline, and we have some realistic expectations in terms of treatment. Because if you're only waking up 1 time a night to pee, it's going to be pretty hard to get better than that. I myself wake up, 1 time a night to urinate. So if I could fix that, obviously you'll be the first to know, but that's normal. And I know that, and it's just part of life. So what happens with overactive bladder? So it can be a dysfunction of the communication between the bladder and the brain. It can lead to an urgent need to urinate, and again, unwanted contraction resulting in leakage. It can make you rush to the bathroom and even lose urine. There's 2 types of urinary incontinence in general: stress and urinary urgency incontinence. So overactive bladder falls in the urinary urgency incontinence, and oftentimes people will have both, and we can call that mixed urinary incontinence. So it's very important to understand that stress incontinence is typically fixed with procedures. Now, overactive or urge urinary incontinence can be fixed with procedures as well, but there's a pathway that we typically follow involving behavioral therapy and medications first. So a lot of ways it's going to affect your life, limited physical activities, Uh, having intercourse and that need to suddenly urinate is kind of a mood breaker, unfortunately. Reduce social plans if you're traveling on a plane and you don't want to have to get up and go to the airplane bathroom several times during the flight. That can be a problem. Also working, especially even if you're not working from home anymore. I've seen a lot of people when they first started working from home during the COVID times, they didn't really complain a lot about it, but as soon as they went back to work, they realized that I was urinating a ton, but it didn't bother me because the bathroom was right next to my office. And now that I'm back in a work setting, this is becoming a huge problem. Also, issues, psychological problems, guilt, stress, fear of accidents, and pads are expensive. I'm sure some of you are aware. On certain clothing items, you want to avoid wearing white clothing and things like that. It's a big deal. So it is not a normal part about getting older. Not just being a guy or being a girl, and it's not something that you typically did. It's something that just typically happens with time. So there are ways to fix this. So this is one of the big things is that people don't address this. They realize that it's a problem, but they're not willing to go see a urologist or talk to their general practitioner about this. And they just kind of think that, oh, this is something that I can live with. It doesn't have to be the case, though. So treatment options. In general, we follow patient care pathways with almost anything in medicine. So thing number one is you got to talk about it. So don't ignore this. This is a real problem. This problem can be fixed and not something you have to live with. So typically you'll see your primary care doctor, they'll refer you to a urologist. When you get there, we'll talk about potential symptoms. We'll do like a diary. We'll figure out what are you doing in your lifestyle. If you're waking up every single day and you're having 3 cups of coffee and like 10 Diet Cokes, well, then you're probably going to be peeing pretty frequently. But if that's an issue, we'll figure that out and we'll get down to it. And unfortunately, that's not something that I can fix with surgeries or medicines or anything. That's just a lifestyle thing that we have to work on. And again, this is the pot calling the kettle black. I have 2 cups of coffee and Diet Coke every morning, and I know that it's going to make me pee frequently. But I'm aware of that. I know it's happening, and I'd rather be awake and have to urinate a couple of times. So initial treatment options, we try to limit the caffeine, carbonated beverages. We try some medicines, and then bladder training exercises. So bladder training exercises work pretty well for things like stress incontinence. For overactive bladder, not as much. So once those things that, if they work, fantastic, we get off the train there. If it doesn't work, we move on to advanced therapies. Now, this is a thing that a lot of people don't do. One is because a lot of urologists don't necessarily know about them, or they don't know how to do them, or they don't know how to get people down the pathway. And that's what's a real shame because medicines often fail around 50% of the time. But once you get to the advanced therapies, the effective rating of this is around 85 to 90%. So people are kind of afraid of it and they think that, they don't know if it exists and they're not willing to, go the next step. So those things are sacral nerve modulations, PTNS, and Botox, which we'll talk about here shortly. Urinary retention, very similar. You start out with behavioral therapies. We try medications that can potentially open up the prostate, and then we move on again to third line therapies. So initial treatment options, like we said, bladder training exercises. Usually we do relaxation techniques. Kegel exercises don't work so great for overactive bladder. There is something called a quick flick, which is where whenever you feel the urge to urinate, you kind of squeeze your pelvic floor muscles several times in a row. That sometimes can suppress the urge to urinate. We also recommend trying to delay your urination. So if you feel the urge, try to hold it the best you can. Oftentimes that doesn't work, it fails. Then other biofeedback exercises that we have. Again, avoiding caffeinated beverages, alcohol, caffeine, spicy foods. That's recommended for anybody that can start doing that today even. Medications, there's 2 overall types, beta-3 adrenergics, and then there's anticholinergics. So beta-3 agonists, they relax the bladder. They essentially prevent the bladder from squeezing so hard in order to urinate. Anticholinergics kind of do the opposite. They block the actual contraction itself or the squeezing of the muscle. The anticholinergics are things like oxybutynin, is one of the oldest ones, but all of them have side effects. Anticholinergics, typically a side effects is going to be things like dry mouth, constipation, dry eyes. Beta-3 agonists, Gentessa and Mirabegron are the 2 that are out there. They're very expensive. Oftentimes insurance does not cover the newer drugs, the beta-3 agonists. Side effects, not nearly as many as the anticholinergics, other than big side effect to your wallet. But also they can sometimes raise your blood pressure just a little bit. So advanced therapies. So PTNS is one of those. This stands for peripheral or percutaneous tibial nerve stimulation. So it's kind of time consuming. You have to come to the office. It's 12 sessions. It takes around 30 minutes to do. So every week for 12 weeks, you have to come to the office. We put a little needle kind of in the tibial nerve through your ankle, and then it sends an electrical signal up into the bladder. Essentially, it kind of reprograms the bladder. This works similarly to sacral neuromodulation, which is what Axonics is a part of, except for it is a lot more involved and pretty time consuming, and honestly not quite as effective because you're not actually stimulating the nerve directly. You're going up the tibial nerve. So usually around 5 to 6 sessions before you start to see anything. And if it helps, you have to do this forever. This is not something that you can do 12 of these and it just fixes it. You keep having to come usually around once a month forever until, I guess you die because it doesn't go away. Botox. So Botox is an option. This is just like the Botox that you do into your face muscles for wrinkles. So just like when you inject it in the face, it helps relax the muscles so they're not squeezing so tightly. It's the exact same thing. It is poison. This is what it is. Botox is one of the most powerful poisons known to man, and we inject it directly into the bladder. It works. So pretty well. Unfortunately, it works too well in about 10% of the population. So we inject this poison in there and it makes the bladder not squeeze as frequently. 10% of the population is unable to urinate. So can't urinate, you're stuck with a catheter, usually for maybe a month, maybe a couple of weeks, sometimes longer. Typically lasts around 4 to 6 months. So you have to do this, forever, every 4 to 6 months. This is not a permanent solution, but it is one that can be done in the office relatively easily. Sacral neuromodulation, this is what Axonics is. So SNM, what it does is it modulates the activity of the nerve and it helps restore bowel and bladder function. The good news about it is you can actually kind of try it before you buy it, is the way I like to think about it. Very few times in medicine, almost, I can't really think of one off the top of my head, can you actually do a temporary trial run of a procedure to see if it's going to help you. If your knee goes out and needed knee replacement surgery, you can't just get a trial knee replacement and then, if it works, then you get the real deal one. So this actually, you can do that, which we'll talk about here shortly. If the trial is successful, you can do a permanent implant. It can last for up to 5 to 15 years. So Axonics. So safety information, the implantation of this is other things associated with surgery. Some of this means anesthetic intervention, such as infection or potential removal of it. Overall, this is a very safe, very easy procedure. Takes around 30 minutes or so to do in the operating room. So sacral neuromodulation is a AUA, American Urologic Association guideline recommended therapy, helps restore normal bladder and bowel function. It's indicated for overactive bladder, retention, and fecal incontinence. So how does it work? So these OVB, incontinence, retention, usually associated with an abnormal communication between the brain and the bladder and the bowel as well. So it provides stimulation to the nerves that control these things. And the stimulation can restore the normal connection between the bladder and the brain.
Symptoms like yours can be caused by abnormal communication between the brain and the bladder or bowel, which disrupts your daily life. Axonics therapy provides gentle stimulation of the nerves that control the bladder and bowel, restoring normal communication to the brain and resulting in an improvement of your symptoms.
So it's just a little graphic of kind of like how it works. So again, the first step is that we do the trial run. That's the beauty of this, is that when we do the real implant, we do the actual surgery, I know it's going to work because we already tested it. So the way the trial run works is you come to the office. We just use some local anesthesia. We put a little thin, tiny lead into the back. We connect this to a battery that we tape to the back. And then usually for around 3 days or so, you walk around with this device. During those 3 days, we're going to be monitoring the response that you have to the device. Now, oftentimes I'll do these things. Around 85 to 95% of people who have the trial done actually move on to get their permanent implant. In fact, oftentimes when I see them in the office 3 days later to take out the temporary lead, people get pretty mad at me because for the first time in years, they're having relief. And so they're upset that I take out this device. But fortunately, we get them in very quickly to do the permanent implant. So the implant we have, there's 2 of them for Axonics. This is a small rechargeable one. It's about the size, 2 quarters. So it's a very miniaturized rechargeable implant. It's done via a minimally invasive outpatient surgery. It takes me around 30 minutes or so to do. It's real simple, one tiny little incision in the back to fit the battery. Now there is a new battery actually that we don't have a picture of here that actually can be non-rechargeable. It lasts around 15 years or so. The rechargeable battery in theory will last for 15 years. You have to recharge it around once a month. maybe longer, honestly. So 15 years is what the company says, but in reality, it will last much longer than that. You just may have to recharge it more frequently. Just like if you have an iPhone, you usually after 3 years or so, instead of charging it 1 time a day, you have to charge it potentially 2 times a day. Also, the old devices were not MRI compatible. So this device is, which is fantastic. It's got a special ceramic covering over it. So you can have an MRI. This will not disrupt any of the other things that you would need potentially imaging wise. There's a remote control that you carry around to kind of increase it. If you want to go change the different programs, different modes, you kind of tailor it to what works best for you. Oftentimes people will set it and then they just kind of forget about it because it's constantly running in the background and your brain kind of turns off the stimulus. So you don't feel it anymore, but it's still actively working. And then once you get set up, people usually just kind of put the remote in a drawer and just never change it again once you got a nice, comfortable level. So the charging system, it's a little battery looking puck. You just wear it on the back. It takes around, you can do it in less than 60 minutes, usually around once a month. If you want to do it twice a week, you can do it for around 15 to 30 minutes. It's very, very simple to do. And again, with the newer device, the battery's a little bit bigger, but it can last up to potentially 15 years with no recharging necessary. Again, 94 to 98% of people, the charging is not a problem. It just doesn't really bother them at all. So people are very pleased with it. So this similar concept. Around 93% of people have clinically significant improvements in incontinence symptoms at 2 years. That's huge. Oftentimes in medicine, you can't say 93%. That's an amazing number. Very rarely do we get things that well. So after the implant themselves, 94% of people are happy and 93% of people would do it again. I think that's the biggest telling statistic, is that if you're willing to do it again, willing to go the trial and the implant and everything, well, obviously it was worth it. So again, it's life-changing kind of thing. So we can get you set up for a consultation. We can test it before you buy it. That's again my favorite part about this, is that you can trial run the therapy before anything else, so that when we actually do the surgery, we know it already works. And so it's just a matter of time of getting everything set up.
Thank you, Dr. Wyatt. It was a pleasure hearing from you and your experience with treating patients suffering with bladder dysfunction. Okay. Is this therapy for men and women?
Absolutely, yes. Yeah, I've almost half and half, in all honesty. Usually women are the ones that typically hear about it first, because again, guys who tend to just ignore problems before they become a huge issue. So it usually takes them a little bit longer to get in the office. But yeah, absolutely, men and women.
Is there an age this works best for?
No, honestly, I've done these in 20-year-olds, and I've done them in like 90-year-olds. Last week, I did one in a 92-year-old female, and she loves it.
Seeing a lot of questions come through about insurance. Is this covered by insurance?
Absolutely. All major insurance companies do this. The only thing with insurance is that what they want us to do, we got to play the game. So that's the problem with insurance, is we have to try 2 medicines. So you try one medicine. If that fails after a month, then we try a second medicine. If that fails after a month, we have to say that you tried them for a month, or otherwise insurance will say no. But then after that, absolutely, they 100% cover it. We just have to play the game and say that you tried the medicines and they failed. And oftentimes they do. 35 to 50% of the time, the medicines don't work as well. They don't work at all, and they have pretty debilitating side effects. So yes, on a long roundabout way, yes, absolutely.
Is this recommended after a TURP?
Sure. So the thing about TURP is a TURP or a T, so transurethral resection of the prostate is what a TURP is. Essentially, it's when you go in with a little machine and you root the prostate, you open it up. So if your prostate is big and it's kind of collapsing in your urethra like this, it opens it up to make it easier to urinate. Now, a TURP is designed for a enlarged prostate or obstructive bladder symptoms. Men typically will have both problems. So if for years you've been having issues with an enlarged prostate, that can damage the bladder over time. And so we fix the prostate problem. So the stream is better, the flow is better, you're emptying better. But now that you're emptying better, you realize that you're peeing very frequently and urgently. So that's where you get the overactive bladder issue, because the prostate led to indirectly damage of the bladder. So we can, and yes, again, long story short, yes, it is indicated for that, because by fixing the bladder issue and have previously fixed the prostate issue, you fix both problems.
This kind of goes into the next question someone asked, does this help with an enlarged prostate?
It does not help with an enlarged prostate. So an enlarged prostate is again, a bladder outlet obstruction issue. So that's fixed with things like alpha blockers or Flomax, tamsulosin, and other procedures such as a TERP or UroLift or Resume, all of those things of which I do. So it will not help with the prostatic enlargement, but it can certainly help out with symptoms associated with prostatic enlargement and bladder interim damage.
This is a good one. What's the difference between OAB and IC? Which I'll
Sure.
let you tell everybody what IC is. I don't.
Yeah. So OAB, overactive bladder, which we just talked about, that's frequency urgency. IC stands for interstitial cystitis. Now, the thing about interstitial cystitis or IC is that there are many, many, many associated side effects with that. IC can lead to frequency, urgency, urinary incontinence, all the things that OAB has. Oftentimes, though, it's also associated with pain and with discomfort in the bladder in the perineal or pelvic area. So that's kind of what defines IC, is usually patient bother and pain with all the symptoms of OAB. Now, that's actually an excellent question, because if you look at AUA guidelines, American Urological Association guidelines for interstitial cystitis, this is a tier 4 treatment for IC. So you start at tier 1, which is behavioral therapy. Tier 2 is going to be things like potential medicines by mouth. Tier 3 is going to be installations in the bladder with certain chemicals that can kind of relax the bladder. And then tier 4 is, boom, right there is going to be sacral neuromodulation, which is what this is. Tier 5 is things like chemotherapy. And finally, tier 6 is going to be removal of the bladder. So very, very, very rarely do we ever get to 5 or 6. But I have plenty of interstitial cystitis patients that I've done this on, and it's changed their lives for both frequency, urgency, and for pain.
If I'm waking up 2 times in the night to pee, do I need to consider this?
Potentially, yeah. So 1 to 2 is pretty normal. It depends on your bother. So if 2 times is too much for you, then yeah, sure, you can absolutely consider this. If you're okay with 2 times, again, I wake up 1 time a night, and so I'm not overly bothered by that. Eventually, it probably will be 2 to 3 times, and then yeah, certainly I will be considering this.
Is this device effective post-prostatectomy surgery?
Absolutely. I've done this on post-prostatectomy. I've done this on post-radiation. So yes, absolutely.
Can you feel the device when you sit or lie down?
No. The only way you can feel it is if you put your finger over where the incision is and you push pretty hard. You can feel a tiny little hard spot, and that's it.
Is this procedure successful for incontinence resulting from removal of your prostate?
No. Well, maybe, I guess I should say. So typically removal of the prostate is going to be coughing and sneezing incontinence. But if you have overactive bladder that's resulting in incontinence, then yes, absolutely. And it sometimes can be hard to tell the difference between coughing and sneezing and having leakage versus just urgency and frequency. So potentially, I would say.
Okay.
And we'll have to kind of ask some questions and do a diary and kind of get to the bottom of it before I could better answer that on a case-by-case basis.
Is this procedure done under general anesthesia in your outpatient clinic?
The trial is done with just local anesthesia, and we just do that in the office. And the implant, the full implant, yes, is done with some general anesthesia, with kind of like a colonoscopy anesthesia, and it's done outpatient, yes.
It's kind of like similar to the TERP. If you have aquablation, does this work? Can Axonics work afterwards?
Absolutely.
Yeah. Once I get the implant, how often do I need to be seen?
Honestly, I see people about once a year. So I do the implant, and then 2 weeks later, we touch base just to make sure that everything's healing okay and that you're happy. And then after that, honestly, I see people once a year just to see if they're still doing okay. People usually cancel that appointment and they just don't come back for 5 to 10, 15 years because they're doing so great. But that's totally up to you and how you want to do things. But I like to see people at least once a year just to know that they're still doing okay.
Yeah. Through all tiers, will you have to change your daily habits? Example, a glass of wine, or cut off when you drink water. For women who currently wear disposables, will this procedure eliminate leakage even when you hear running water?
Potentially. So I don't like to say the word eliminate because I think I don't want to sell false hope here. Potentially, if we quote people greater than 50% reduction in their symptoms. Oftentimes it's much better than that. Can it eliminate? Absolutely. Will it 100% eliminate? I can't guarantee that until we potentially do the trial. Has it before my practice? Absolutely. In terms of changing your behavior and your lifestyles, not necessarily. I have plenty of people who still drink wine after they've had this procedure and they have no issues with it at all.
And that brings us to the end of this evening's webinar. Thank you, Dr. Wyatt, for your time. We hope the presentation was beneficial. If you would like more information or to schedule an appointment, please call Dr. Wyatt's office. Thank you for joining us, and we hope you enjoy your evening.